Yes, please. Thank you.
Sounds great. So welcome to Internal Medicine Grand Rounds, and it's Nephrology's pleasure to present. And I'm thrilled to have a guest speaker, Dr. Matthew James. Matt is a UBC alumni where he did his medical school. And I think that's the last time I worked with him clinically, and probably the last time I could have ever taught him anything as a medical student. So I'm pretty happy for that. He did his training in Calgary and has a PhD in epidemiology as well as his nephrology training. And he has such a large body of research in AKI and cardiovascular disease and CKD outcomes. So Matt, welcome. And thank you so much for coming back to UBC to present today.
Well, thanks very much for inviting me and the opportunity to talk. I'm going to be speaking about cardiac outcomes of people with chronic kidney disease today, approaching evidence-informed decision-making. I'm just going to make sure I can get these slides moving. There we go. So I'll just start with some disclosures of my grant funding is from the Canadian Institutes for Health Research, Alberta Innovates, and also funding through the CanSolve Chronic Kidney Disease Network. And I also have some funding from Angina in Canada related to acute kidney injury detection. So the objectives of this talk, I'd like to try to cover three major topics. The first is to review some of the risks of cardiovascular disease and how they vary across the spectrum of chronic kidney disease. For the second objective, I'm going to focus on really the evolution of some medical therapies for prevention of cardiovascular disease as they've evolved over the last 20 years for people with chronic kidney disease. And then the third objective will be to focus more on recent evidence of the impact of invasive management strategies. And I'm going to be focusing on coronary artery disease largely today, although there's many other relationships between kidney disease and cardiovascular disease. I found that 1 hour is really only allows me to get through actually coronary disease and not some of the other types of cardiovascular disease. So this is a figure just to start off, showing two figures from studies done several years ago now that showed the relationship between kidney function and cardiovascular risk and outcomes. The first figure on the left actually showed that as kidney function progresses or as eGFR declines, there's an increasing risk of developing a cardiovascular event. And so this actually rises from about 2% for people who have normal kidney function to over 30% for those with kidney failure or a GFR less than 15. The figure on the right actually shows outcomes, a number of outcomes by different levels of kidney function for people after they've been hospitalized with a myocardial infarction. And what it shows is that as kidney function declines, the risks of death from cardiovascular causes, having another myocardial infarction, heart failure, stroke, or resuscitation all increase with lower levels of kidney function. More recently, a lot of work has been done across many cohort studies of patients with chronic kidney disease to better characterize the relationships between both eGFR or kidney function, shown here on the left, and proteinuria or albuminuria, more specifically here on the right. And what these figures show are pooled results across many cohort studies where patients have been had eGFR measured and proteinuria measured in both those with diabetes in red and no diabetes in blue. And what this shows is the consistent relationship between declining GFR and increasing risk of cardiovascular mortality. And the same with increasing albuminuria. We see both in patients with and without diabetes increasing risks of cardiovascular mortality. And those relationships are generally higher for people with diabetes, particularly when kidney function is normal. But as kidney function declines, both groups start to have extremely high risks of cardiovascular death. This figure is some work from Alberta that actually took a cohort of patients from Alberta and actually characterized them based on having a previous myocardial infarction, having diabetes or chronic kidney disease defined by a GFR less than 60, or only diabetes, chronic kidney disease, or none of these conditions.
Just a second. Can we just ask everyone to mute their phones, please? Thank you.
And what this figure shows at the top is actually the risk of myocardial infarction in these groups. And what we've characterized for many years is that people who had a prior myocardial infarction, which is the group shown in gray here, is considered to be a very high-risk group. But you can see that people in the green bars who have both diabetes and chronic kidney disease actually have risks of experiencing a heart attack or a myocardial infarction that actually approaches that risk of those who've already had one in the past. And we can see if in the lower figure that if we look at all-cause mortality, actually that risk in patients with diabetes and chronic kidney disease is even higher. So people with diabetes and chronic kidney disease are a very high-risk group for cardiovascular events. And this is a figure that attempts to summarize a lot of information about the relationships between kidney disease and cardiovascular disease. And this came out of a kidney disease improving global outcomes conference. And what it attempts to show as you move from left to right on this figure is that as kidney disease progresses, at the top triangle, we see this increasing risk of experiencing a new cardiovascular event. In the yellow, it's representing atherosclerotic events, which rise quickly in risk in the early stages of chronic kidney disease. But then this risk is actually added to by a number of other non-atherosclerotic contributors. So this includes arterial calcification, arrhythmias, structural heart disease, as well as others. And so we see this increasing magnitude of both atherosclerotic, arteriosclerotic, arrhythmias, and structural heart disease as kidney disease progresses. And the lower triangle in green is showing the risk of death after a cardiovascular event. And so how the prognosis of patients with kidney disease and having had a coronary event worsens as kidney disease progresses. And I just wanted to touch a little bit on this study, which was a case control study that actually looked at how patients with different levels of kidney function first presented in terms of with coronary heart disease. And what the rows show are declining levels of kidney function, and then a number of models that actually represent the odds of initial presentation with an acute coronary syndrome. And really the message from this study is that actually the most common first presentation of coronary artery disease in patients with chronic kidney disease is actually acute coronary syndromes, and particularly non-ST elevation acute coronary syndromes. And actually, although stable coronary disease is actually very common, it's largely and often an asymptomatic or oligoanginal syndrome where many patients do not initially present with prominent anginal symptoms. So needs to be an index of suspicion for coronary events, even in patients without angina. And this issue of coronary artery disease and cardiovascular disease in CKD is not only important to physicians, but this is some work that was done at the outset of the CanSolve network's development over 6 years ago now, that actually looked at priorities of patients with chronic kidney disease, both those on or approaching dialysis and end-stage kidney disease, as well as those at earlier stages of chronic kidney disease. And actually questions related to strategies for lowering cardiovascular risk and improving heart health were priorities for research by patients in both of those groups.
I just want to get the serial number of the computer.
So I'm going to move on now to talk a little bit about some different medical therapies and their effectiveness in chronic kidney disease and what we've learned over the last 20 years. So I'm going to start with hyperlipidemia, which is well recognized in the general population as being a risk factor for coronary artery disease. And what this figure is data from Alberta that actually just looks at the relationship between LDL cholesterol, which is often recognized as the prominent cholesterol related to coronary artery disease development and outcomes. And what the figure shows is actually the relationship between increasing levels of LDL cholesterol and the risk of having myocardial infarction. And these different panels actually break it down by different levels of kidney function. So starting up on the top left is actually the lowest level of kidney function. So people with kidney failure or a GFR less than 15. And then as we move to the right, we go to higher levels of kidney function, 30, 16, eventually above to normal kidney function. And what I just want to point out on these figures is how the slope of these curves change and actually flatten out as you get to lower levels of kidney function. So that strength of that relationship between increasing LDL and risk of having a myocardial infarction actually starts to become attenuated as we develop more advanced chronic kidney disease. And this fits with some of the biological understanding of how coronary disease evolves in more advanced chronic kidney disease, where we see more atherosclerotic disease, particularly a larger burden in earlier stages of chronic kidney disease, and then progressively add more arterial sclerotic disease as kidney function progresses and we enter end-stage kidney disease or kidney failure. But lipid-lowering therapies with statins and other agents have been extensively studied in patients with chronic kidney disease, both those on dialysis treatments and those with earlier stages of kidney disease. And one of the largest studies, the largest study in this population of chronic kidney disease was the SHARP trial, which was a trial of cholesterol lowering with a statin, simvastatin, and ezetimibe compared to placebo in patients with chronic kidney disease. And these were patients both with earlier stages of chronic kidney disease as well as those with kidney failure receiving dialysis. And what the overall results of the SHARP trial showed was that it was a significant reduction in atherosclerotic cardiovascular events. So this was coronary mortality, myocardial infarction, ischemic stroke, and revascularization, coronary revascularization in patients treated with simvastatin plus ezetimibe compared to placebo. And there was a 17% risk reduction observed in the trial. The trial also looked at these effects across different levels of kidney function. So we have at the top here, patients in the trial stratified by their GFR, stratified by different levels of albuminuria. And then at the bottom, we actually have the subgroup of patients in the trial who were on dialysis. So there were more patients in this trial who had chronic kidney disease beforehand. And you can see there's a very consistent effect actually observed in these patients across levels of GFR and albuminuria in terms of reducing their risk of an atherosclerotic coronary event. When you look at this, it appears that there's less strong effect or no effect in patients who are on dialysis. This is a smaller group of the trial. When this trial formally tested for an interaction or to see whether the treatment effect was different between patients who weren't on dialysis and those who were on dialysis, they actually didn't find evidence of a significant difference here. Although I'd argue that when you look at these point estimates, you start to wonder if there's overall a difference in the two different populations. But there were a number of other trials going on around the same time and slightly before, looking at statin therapy specifically in patients on dialysis. And this was a large trial, the Aurora trial, that randomized patients to rosuvastatin or placebo. And this was a hemodialysis population. And what this trial found was that there was actually no effect on the primary endpoint, which was a major first cardiovascular event with statin treatment compared to placebo. In 2012, this meta-analysis was published, which really does a nice job of summarizing the effects of statin treatment in people with chronic kidney disease and further teasing out this question about the efficacy of statin therapy at different stages of kidney disease. So the way the results are presented here, we have a number of different outcomes. First is all-cause mortality, cardiovascular mortality, major cardiovascular events, and then fatal and non-fatal MI. And then we have trials stratified by whether they included populations or subgroups with patients with CKD not receiving dialysis, patients on dialysis and transplant. And what you can see across really a number of all of these outcomes is that there's a fairly consistent effect of statin treatment in terms of lowering cardiovascular on all-cause mortality as well as cardiovascular events that's seen in people with kidney disease not on dialysis, but that effect seems to no longer be seen in patients by the time they're reaching end-stage kidney disease on dialysis. The trials from transplant are fewer and the numbers are smaller, so there's much more uncertainty about the effects in patients with kidney transplants, but there does seem to be a signal of effect, at least on non-fatal events in transplant patients. What these columns on the right show is that actually the stage of kidney disease is the major explanatory factor for differences in the trials. So most of the variability between trials could actually be explained by the nature of the population, whether this was patients with earlier stages of kidney disease or actually had kidney failure. I'm going to move on to some more recent evidence and shifting next to the literature that's evolved recently around SGLT2 inhibitors. And in nephrology, we've been very focused on them for their effects on preventing progression of kidney disease in diabetic and probably non-diabetic nephropathy as well. This started to really become notable with the Credence Trial, which was done in patients with type 2 diabetes and chronic kidney disease with a GFR between 30 or 90 and albuminuria. And all of these patients were actually being treated with renin-angiotensin system blockers. The patients were randomized in the Credence Trial to canagliflozin versus placebo and were followed for over 2 years. And what this trial showed was that SGLT2 inhibition actually led to a lower composite primary outcome, which was a doubling of creatinine, end-stage kidney disease, kidney death, or cardiovascular death. But the trial also included a number of secondary cardiovascular outcomes, and there was certainly a number of trials not limited to people with kidney disease that looked at SGLT2 inhibitors in patients with diabetes and cardiovascular events preceding this trial as well. But what was seen also in the Credence Trial in the CKD population was a reduction in the risk of a number of secondary cardiovascular outcomes, including cardiovascular death or hospitalization for heart failure, atherosclerotic events as well, MI and stroke, and hospitalization for heart failure, with effects that were between 20 to as high as 40% risk reductions. And then there was another trial, even the dapagliflozin trial, that not only enrolled patients with diabetes, but also included a fairly significant number of people with chronic kidney disease and proteinuric chronic kidney disease that was not due to diabetes, including a fairly substantial number of patients with IgA nephropathy, and had a number of other similar factors. Otherwise, these are patients that were largely treated with renin-angiotensin system blockade already, and we're comparing SGLT2 inhibition to placebo. And this trial again showed a reduction in kidney as well as cardiovascular endpoints, with the secondary cardiovascular endpoints are shown below here, with about a 30% reduction in death from cardiovascular causes or hospitalization for heart failure. The wealth of data that's now evolved on SGLT2 inhibitors has been very nicely summarized in this network meta-analysis that's part of an analysis that looks at a number of different diabetes therapies, but does a very nice job of summarizing the absolute risks that are associated with SGLT2 inhibition. It stratifies the trial results by risk stratus, but within this framework that they've used, patients with chronic kidney disease would actually be in the high risk status here. And if you look at the absolute risk reductions that are come from these trials, if you look at the CKD trials, what they suggest is that if you treat 1,000 patients with SGLT2 inhibitors, you could prevent 34 deaths, 16 fewer cardiovascular deaths, 14 fewer myocardial infarctions. And the very high risk group in this meta-analysis is actually patients who have chronic kidney disease and already established cardiovascular disease. So the absolute reductions in number of events are even higher in this group that has established chronic kidney disease and cardiovascular disease. And going to end this medical therapy kind of session of the talk just by highlighting some of Stephanie Thompson's work. She's a colleague of mine up in Edmonton who has looked at the use of cardiac rehabilitation among people with kidney disease, just to remind ourselves that lifestyle and risk factor reduction strategies likely play an important role in secondary prevention as well. So this was an observational study that looked at the utilization of and outcomes of cardiac rehabilitation, which is provided as a multifactorial lifestyle and risk factor intervention in Alberta. What her study actually showed is that, and this is actually seen regardless of whether patients have kidney disease or not, is that there's an attrition of patients after a cardiovascular event from being referred to cardiac rehab to actually getting into the programs and starting it to actually completing them. And you can see that for both groups that the number of patients who are making it to cardiac rehab and completing these programs actually falls as over time. But that fall is actually even greater in people with chronic kidney disease and people without. Notably, these were older patients with more comorbidities in the chronic kidney disease subgroup of this study. But when we actually look at a number of outcomes for people with and without chronic kidney disease, we can see that patients with chronic kidney disease appear to have the same potential to benefit from cardiac rehab participation as those who don't. And this has been actually shown in randomized controlled trials that these programs can reduce cardiovascular death and cardiovascular outcomes. So something to keep in mind for our patients with chronic kidney disease who may be more challenged to participate in the typical programs that are provided. So I'm going to just end with this section on medical therapies and prevention in cardiovascular disease and chronic kidney disease, just by reflecting on, the progress and medical therapies that have, actually started to accelerate over 20 years now of investigation, moving from, back in 2001, the dawn of studies showing blockade of the renin-angiotensin system improving cardiovascular and renal outcomes, to statin and cholesterol lowering, and now most recently a lot of new evidence around agents that were developed for treatment of diabetes, but probably are not only for the SGLT2 inhibitors effective in patients with diabetes, but those without and with chronic kidney disease as well. And we're even seeing more therapies now. I'm not going to get into the evolving and emerging literature on the non-steroidal mineralocorticoid receptor antagonists, but that is starting to be seen as well, and maybe a further effective therapy that we can figure out to use safely in chronic kidney disease. So I'm going to shift now to some of the issues and evidence around questions around invasive management of coronary heart disease and chronic kidney disease. We've seen that the risk and prevalence of coronary artery disease is high in this population. And so it's of interest to ask whether invasive therapies would be beneficial. Of course, these therapies are associated with contrast dye, ischemia, reperfusion injury from surgery, potential for atheroemboli with surgery and catheterization procedures. So there's also a significant potential for risk of harm in patients with chronic kidney disease. But in the last year, actually, there was some important literature that evolved in this area that came from a series of trials called the Ischemia Trials, which were trials looking at invasive or routine invasive management of stable coronary heart disease. And what was really important about this is, and overcomes a challenge that's happened in a lot of other studies of cardiovascular interventions, is that not only a large trial, the Ischemia trial, was done in patients with normal or relatively preserved kidney disease, there was also a sister trial done called the Ischemia Ckd Trial that specifically addressed the question of routine invasive versus medical management in patients with chronic kidney disease. So I'm going to start with that Ischemia chronic kidney disease trial. It was focused on patients with kidney disease who had an eGFR less than 30 or had kidney failure and were receiving dialysis. So it was an advanced chronic kidney disease, pre-dialysis, and end-stage kidney disease population. This was a trial of patients with stable coronary heart disease, so not acute coronary syndromes. And all patients in the trial had moderate or severe ischemia on stress testing. So this was largely stress echo and myocardial perfusion imaging. The intervention that was studied was an initial invasive strategy, which would involve proceeding to coronary angiography plus or minus revascularization, which could be percutaneous or surgical, depending on the nature of the disease found and the decision of investigators at that site, versus an initial conservative strategy, which would be optimizing medical therapy and using invasive approaches only if medical therapy or attempts to use medical therapy failed. And the follow-up in this trial was about 2.5 or 2.2 years. So this is the characteristics of patients in the Ischemia Ckd trial. It was 777 patients, mainly men, some on the kidney transplant waiting list. About 12% were on a wait list for a kidney transplant. About half of the patients were on dialysis, on average 2 to 3 years, and 80% of them were on, over 80% were on hemodialysis. The rest had chronic kidney disease not receiving dialysis, with a median GFR of 23 mils per minute. As mentioned, all had to have moderate or severe ischemia on non-invasive imaging tests. And what's notable is actually the degree of angina symptoms actually was not that high in this group of patients. So the median Seattle angina score was around 80. So this is a score that ranges from 0 to 100, where 100 would be the best health status and 0 would be the worst health status or the most symptomatic. So they actually had fairly good anginal symptom scores. And that's reflected here if you actually look at the breakdown of how much angina these patients were having. Half of this patients in the trial, despite having moderate to severe ischemia, actually had no angina, which really speaks to the difference in symptoms that patients with kidney disease can have with less angina when they have coronary artery disease. And only about 12% of patients actually were having what would be considered like significant to severe angina. The primary outcome of the Ischemia Ckd trial is shown here. So that was death from any cause or myocardial infarction, and there was no difference between the group treated with initial invasive strategy or conservative strategy. And this was consistently seen across the secondary outcome of the trial as well, which also included hospitalization for unstable angina, heart failure, and cardiac arrest. So how does this compare with the sister larger ischemia trial? Well, actually, in terms of these outcomes of cardiovascular mortality and cardiovascular events, actually, the findings are very consistent. The parent ischemia trial also did not show a reduction in the incidence of cardiovascular events or death in the invasive treatment group than in the conservative treatment strategy group. However, turning back to the Ischemia Ckd trial, what was concerning is there was this signal of harm actually seen in the population of patients who were not already on dialysis. So that 50% of the trial population actually had about a 30 to 40% increase in risk of death from any cause or initiation of dialysis. And most of this effect appeared to be driven by initiation of dialysis being more frequent in the invasive treatment arm. The trial has also gone on to produce results for about 194 of those patients who are actually on the transplant waiting list, which is of great interest to us in nephrology, because this is a large concern about our patients going for kidney transplant and whether their cardiovascular status is optimized to proceed with surgery, both for their own risk and also considering the desire to see organs that are transplanted survive. So this was an analysis of the 194 patients who were on a kidney transplant wait list. And actually, it showed very consistent findings to the main analysis as well. So there was no difference in the outcomes between those who received invasive management and those who did not. This trial also did a very thorough job of actually looking at the effect of these interventions on health status or symptoms. So I want to spend a little bit of time looking at that from the Ischemia Ckd trial as well. So there were a number of different instruments used in this trial, but I've shown two here. The first is the Seattle Angina Questionnaire Summary Score. Again, this is a score that ranges from 0 for the worst anginal symptoms up to 100 for the least. And what it showed actually was that, both groups, the medically treated as well as the invasively treated group, experienced improvement in their symptoms in the first 3 months. But overall, there was no difference across all the patients in the trial, but in these anginal symptoms between the two treatment groups. The figure on the right here shows the Rose dyspnea scale. So really addressing the fact that sometimes actually anginal equivalents are more common in this chronic kidney disease population. But again, the effects on health status here show that there was initial improvement in dyspnea. So the direction here is the opposite. Lower scores here would be worse. So there was actually lower scores here would be better. So there's actually an initial improvement in shortness of breath or dyspnea, and then again, no difference between the two groups over the course of the trial. But what is a little more complex is dealing with the issue that so many of the patients in the Ischemia Ckd trial were actually relatively asymptomatic at baseline. So actually, if you look at this figure, what this actually shows is the distributions of the change in the Seattle Angina Summary Score at 3 months, 12 months, and 36 months as we move from the top to the bottom. We see it in a number of columns here. So first, overall, where we see, overall no effect of the intervention. But when you actually break this down by the degree of angina patients had at baseline, we actually start to see a bit of more nuanced picture where patients who actually had daily or weekly angina at baseline, who were a minority in this trial, actually had a significant improvement in their angina at 3 months. This was about a 10% difference in the SAC summary score, which is actually felt to be clinically significant. The caveat, however, is that improvement actually started to disappear by 6 months. And by 1 year and beyond, there was again no difference, even in this most symptomatic group in anginal symptoms. Not unlike the sister larger ischemia trial, patients who had less angina, which made up the majority of the trial, didn't show benefits in their anginal symptoms. So we see no effect in the patients with monthly angina or no angina at baseline, which isn't surprising. So really, these effects on health status are very much determined by the degree of symptoms at baseline. And there may be some early improvements in symptoms, but they did not seem to be sustained in the CKD population in this trial. This varies a bit from what was found in the sister larger ischemia trial, because here they actually saw, again, an improvement at 3 months in the entire trial population, with this actually being driven largely by patients who had the most significant chest pain to begin with, and less benefit to no benefit in those with little to no ischemic symptoms at baseline. But what was different in the larger trial population was that the effects of intervention actually were sustained. So there were differences that were sustained out to a year and beyond in the larger ischemia trial of patients without kidney disease, which weren't seen in the Ischemia Ckd trial of patients with kidney disease. I'm going to just mention the work being led by several people at your institution that's actually exploring, the strategies for screening for coronary disease in patients who are on the kidney transplant list. So this trial is actually addressing the question of, once patients are placed on a kidney transplant list, what should be done in terms of screening for coronary artery disease. This trial is randomizing patients in Canada and Australia to either a regular screening protocol for patients on the wait list, where they're screened every 24 to, I think, 12 months, depending on different criteria, using different strategies, and then intervening on screening findings according to local transplant standards of care, versus a strategy of not performing this intermittent screening once patients have been placed on the wait list. And this trial is going to actually examine the effect of these different strategies on major adverse cardiovascular events in patients who are waiting for kidney transplant, as well as the degree of testing and effects on costs that these different strategies would have. I'm going to switch now just to finish up around the topic of acute coronary syndrome, because as I mentioned earlier, actually more patients with chronic kidney disease will present with an acute coronary syndrome as the first presentation of their coronary disease. So the trials of invasive management for acute coronary syndrome were done more than 10 to 15 years ago now. So this systematic review actually summarizes the information from those trials for people with kidney disease. Most of these trials excluded patients with severe or end-stage kidney disease, but as a number of the exclusion criteria were based on higher levels of serum creatinine, there were a number of patients with chronic kidney disease who ended up being enrolled into these randomized controlled trials. So this meta-analysis actually summarizes the literature on those subgroups of patients from trials. So this summarizes data on patients with CKD with a GFR less than 60. None of these patients are on dialysis. And this includes patients who had unstable angina or non-ST elevation myocardial infarction. And this is comparing the strategy of early invasive treatment with coronary angiography plus or minus revascularization as indicated or determined, versus a conservative strategy, again, attempting medical management, but with the potential to receive invasive management if medical therapy alone fails. And these are two forest plots that summarize the results only from patients who had chronic kidney disease. So the outcomes here are death and myocardial infarction. And in the general population, these trials have shown that high-risk patients are the ones who benefit from early invasive strategies. And there's an argument to be made that patients with kidney disease are patients at high risk as well. But the overall pooled effects on death and myocardial infarction are largely comparable to those in high-risk general population studies. So about a 20% reduction in the risk of death or MI across the 5 trials that have characterized kidney function. We've looked at this in Alberta in an observational manner with more recent data of patients who've been managed for acute coronary syndromes in Alberta and are captured in the approach registry, and used a observational study design method of propensity score matching to try to balance prognostic factors between patients managed with invasive therapy versus conservative management approaches, and minimize the amount of treatment selection bias in this observational analysis. What this figure shows is the risks of acute kidney injury, end-stage kidney disease, and death across different levels of kidney function and overall in Alberta. And what we found in our study was that there was this risk of acute kidney injury that accompanied the early invasive treatment approach. It's a consistent relative risk that was observed across levels of kidney function. So the largest absolute increase in risk we're seeing in patients with the lowest levels of kidney function. We did not see a difference in incidence of end-stage kidney disease, although precision here was limited. But there was a consistent lower incidence of death in patients who were treated with the early invasive treatment approach compared to conservative management. So potential cardiovascular benefits, but potential trade-offs for kidney function and acute kidney injury, like we've seen in the Ischemia Ckd trial. So I'm going to finish off just by talking about some of the work we're now doing with the CanSolve CKD network, and we're really pleased to be collaborating with Peter Burke and Adir Levin and their team in BC to validate some of this work now. So what we've really been interested in our project through CanSolve is actually how to support our patients with chronic kidney disease, making some of these preference-sensitive decisions around use of invasive therapies for heart disease during their journey with kidney disease. And the first thing we've done recently and are doing some further work on is something called a discrete choice experiment, which is a method to try to quantify patient preferences for a treatment decision. So in this study, patients are actually presented with a number of scenarios where they have a decision. So here it would be a decision whether to pursue an invasive heart treatment approach or a conservative approach. And they're shown varying attributes of those choices. So we identified through some qualitative work what would be the most important outcomes to patients, and then present varying scenarios where those risks and attributes of the treatment decision are presented. And using utility theory, essentially, we can summarize the responses on a survey and actually assign weights to different attributes of a treatment decision and start to characterize how patients weight and value different outcomes and what their preferences would be. So when we did this with about 150 patients in Alberta with chronic kidney disease, we found that, not surprisingly, interventions that improve survival was the dominant outcome, and they received the most weight. So that's actually shown here for the 140 patients in our study, where the most important attribute was the effect of the therapy on survival, shown here in green. The next most important outcomes to patients were the risk of end-stage kidney disease and the risk of having another myocardial infarction. And overall, whether they had an invasive or conservative approach itself was not as important as long as they were having the therapies that gave them the best chance to prolong their survival, primarily followed by minimize their risk of end-stage kidney disease. However, when we did something called a latent class analysis, which actually looks to see whether this is a consistent pattern or whether there are different patterns of preferences, we actually found there were 2 different preference groups of patients with kidney disease. So the first group is really representative of the overall findings that I just described. This makes up about 80% of the patients with kidney disease that we included in this discrete choice experiment. So again, their priorities were focused on maximizing their survival and length of life, and they had lower concerns about risk of kidney injury and end-stage kidney disease. However, there was a smaller group, but significant in size, of about 20% of patients with chronic kidney disease who actually put more weight on avoiding end-stage renal disease, end-stage kidney disease, and procedural complications, including acute kidney injury, and actually had a greater preference towards avoiding invasive procedures. When we tried to explore what were the factors, it was really came down to no obvious clinical factors explained these two groups other than what patients had already described in their goals of care, was how the level of intervention they would want to prolong life. So it actually correlated very well with patients who have, are most accepting of resuscitation and interventions, invasive interventions to prolong life, whereas the second group was most consistent of those who have more focus on conservative and medical therapies alone, and not more aggressive resuscitation status. What we're trying to do now to help inform these decisions is actually combine information from various sources to actually provide patients with kidney disease better estimates of their risk of different outcomes. So the way we've been doing that is this is work done by Todd Wilson, a PhD student who's been working in this area to develop models that we can use predictors of adverse cardiovascular and kidney outcomes, including those that are important and specific for cardiovascular and kidney risk in people with kidney disease, including EGFR, proteinuria, and their comorbidities. And we use this to build models that we can then use to provide more personalized estimates of risks for patients. And this actually is a figure that shows sort of a 2x2 display of two different risks. On the y-axis here, we have the predicted risk of a composite of death or having another myocardial infarction. And on the x-axis, we have increasing risk of developing end-stage kidney disease. So as you move higher up, we have patients with higher risk of dying or having a myocardial infarction. As you move to the right, we have patients with higher risk of developing end-stage kidney disease. And what you can see is actually that if you take all patients with kidney disease, and this includes everybody with albuminuria or EGFR less than 60, there's many patients who have relatively low risks of progressing to end-stage kidney disease in a short time frame, who actually have much higher risks of cardiovascular events. So we can put people actually into a group where we can say you're high risk for death or a cardiovascular event, but low risk for end-stage kidney disease. So we could proceed with different therapies in that group with more confidence than we could this other group here, which actually has the lowest risk of death or cardiovascular events, but the highest risk of end-stage kidney disease, where we could be much more concerned about these invasive therapies. But you can see every point on this figure is an individual patient. So there's actually a wide range of risk profiles that individual patients can actually have. What we've moved on to do then is take these absolute risks that we can predict out of these predictive models, and then we can actually apply treatment effects from the published randomized controlled trials and meta-analyses to actually refine these risks to give patients an estimate of what their risks would be under different treatment options. So we can actually refine this based on existing clinical trials to give our best estimates of prognosis for the cardiovascular versus renal outcomes. Todd's work has gone on a little bit further to actually incorporate the weighting of the different outcomes when we present this data. So we can incorporate the fact that patients put different weight on a heart attack versus a kidney failure with end-stage kidney disease versus survival. So we can actually increase the weighting on the effect on interventions that improve survival and appropriately balance the lower weighting on end-stage kidney disease and recurrent myocardial infarction. And this is something we can do to conduct what's called a net effect analysis, where we can actually try to characterize patients based on their risks and the treatment effects as to whether they'd overall benefit, experience equipoise, or harm. So benefit here would be patients who would have a greater weighted reduction in the risk of death or another myocardial infarction than the increase in risk of end-stage kidney disease, for example. Harm would be a patient who will experience a greater risk of end-stage kidney disease than the weighted reduction in risk of death or a cardiovascular event. So when you do that, these are what the net effect estimates look like for individual patients across the three groups. So we have on the y-axis, we have actually, as you move from the top to bottom, we have greater reductions in the composite of death or myocardial infarction. And on the x-axis, we have greater increases in risk of end-stage kidney disease. The green points actually identify the majority of patients who we would predict to experience net benefit. So their reductions in cardiovascular risk and death would exceed their increases in end-stage kidney disease. Then we have an equipoise group where there would be no significant difference. And we actually have a smaller but significant group of patients who actually are at risk of net harm. So actually having increases in end-stage kidney disease at risk with intervention that exceed projected benefits. And this is a figure that really underscores the fact that trying to simply stratify patients into whether they have net benefit or harm is very difficult based on individual risk factors like age alone, sex alone, diabetes alone, GFR alone. But actually, when we use these risk predictions, actually we do the best job of being able to identify people who are going to be in a net harm or net benefit group here. So where we are now is we're trying to synthesize this information into a decision aid to support shared decision-making for patients with coronary heart disease and CKD that incorporates this type of information. And this just is a display of what our decision aid looks like, which takes patients through the decision that's to be made, explains the treatment options, and then actually starts to present them with individualized risk information on benefits in terms of what the risk of a mortality or another cardiovascular event would be for patients with acute coronary syndrome. For those with stable coronary disease, we show what the effect on the intervention could be on chest pain symptoms. And another important part of the decision aid is it allows a patient to understand and communicate with their healthcare provider what matters most to them. So which of these attributes are the most important? How do they rank them? And how confident are they in their decision making? So we can actually hopefully improve the patient experience and reduce some of the decisional conflict and uncertainty that patients with kidney disease face in this scenario. So I will conclude by just summarizing these 3 points that today I've talked about how chronic kidney disease is associated with a high burden of cardiovascular disease and has some unique presentations and risks. There are more effective medical therapies now than ever to prevent cardiovascular events in people with chronic kidney disease, which I find very encouraging. And the benefits and risk of invasive treatment of cardiovascular disease and coronary disease specifically vary quite substantially by patient characteristics and presentation. And so I think this requires a personalized, shared decision-making approach, and we're currently working on that and really excited to be collaborating with BC on this work through the CanSolve CKD initiative as well. I'd just like to stop here and thank a number of members of the team from Alberta who've worked on these discrete choice experiment studies and the predictive modeling work that is now moving into the decision aid development and working on validating these tools and models in patients in BC. And thanks to the support from the CanSolve network, the approach team in Alberta to collect a number of the data and resources for these types of studies, and the Libin Institute in Alberta as well. And I will stop here and happy to take questions. Thank you very much.
Thanks, Matt, for such a wonderful overview of what we do and don't know and how to treat these patients. And I think a personal thanks to you. You're very humble, but a personal thanks to you from the renal community for trying to systematically answer these questions that have been basically with us for so long. So thank you. Any questions for Dr. James?
Can I maybe ask him, it's very nice talk, I really enjoyed it, about patients that had transplants of their kidneys. What happened with their long-term risk for vascular disease? Does that sort of stabilize, or does it go the same way as people that doesn't have a transplant and some dialysis?
Yeah, obviously we don't have a randomized trial to address that, but observational studies actually do show improved cardiovascular outcomes or a reduction in cardiovascular events in people who have been transplanted than people who are still on the transplant list. So we think they're, one of the best therapies for cardiovascular disease is actually kidney transplantation. So there's a number of contributors in end-stage kidney disease and advanced chronic kidney disease, not only the traditional risk factors like hypertension, diabetes, hyperlipidemia that contribute to the progression of this disease, but probably a number of kidney disease and uremia related factors which contribute to vascular and structural heart disease progression, coronary and valvular calcification, left ventricular hypertrophy, hyperparathyroidism and mineral metabolism, and maybe homocysteine and other factors that affect vascular health. So I think there is a reason to think that transplant is a very important therapy actually for cardiovascular disease and kidney disease.
Dira.
Yeah, I just wanted to add my thanks, Matt, but also there's lots of data about which you've taught us about the importance of visualizing information for patients. And I was quite intrigued by the tool that you're developing with like happy faces and stuff. And what kind of are your initial impressions for the patients? Are they doing? I think we often talk to patients, we draw them lines or we give them numbers, but I do think there's some value to the pictures and really kind of give some plans to systematically use those in clinical practice. I'm just thinking about how much better our conversations might actually be with people if we could say, like, here's the picture of your risk, not here's the number.
Yeah, I totally agree, Adira. I think we've really been trying to now use international patient decision aid standards to develop these tools, and I think those standards show very nicely that communicating risk information is challenging, and presenting it as relative risks, which we typically do in the medical literature, is absolutely probably the least understandable way, and actual visualization of risk is really important as well. So within these tools, we are intentionally using visualization strategies. So those icons to present absolute risks and compare them between treatment approaches for patients. And we're using a human-centered design process as we develop this decision aid and further test it. But I think the feedback from actually patients has been that different patients seem to like different elements, and some get percentages, but some like the visualizations, many do. And actually the physicians, interestingly, quite like having the visualizations as well to actually show a patient. So I hope these tools can be effective strategies to open up that shared decision-making, that opportunity for communication, to make sure that, with healthcare providers, we provide patients with the best information we can for them, and that then we listen to the preferences of the patients once they understand that information, and we can incorporate the personalized risk information and the patient preferences to make better decisions.
We're right on 1 o'clock. Thank you again, Matt, and for everyone. There's an evaluation form as well in your email. So have a good day, everybody.
Thanks, everyone. Thank you very much, Monica.